Okay, we'll start with the basics once again. Kind of back to basics. Fractures and fracture healing. Okay, it's quite a basic thing. It can cover partly about physiology of fracture healing also. Okay, but nowadays they are taking anatomy, orthopedics together, physiology and orthopedics together. So you'll get a kind of clinical applied physiology or applied anatomy. Okay, we'll start with MCQs, the pattern what I'm following so far. So we'll start with MCQs. Are there any students?
There is. Go ahead.
I expect them to say hi or raise your hand or unmute your mic and
Go ahead. There is a.
okay. What is true or what are true about the fracture healing? Okay. Micro movement promotes healing. In primary cartilage, involvement is there. Woven bone is formed in primary fractures. In secondary healing, cartilage involvement is there. Immobilization is golden rule for all the fractures. Okay, these kind of questions where multiple correct answers are there. I'm sure all of you know that these kind of questions are asked in PGI. Okay, so micro movement promotes fracture healing. That is correct. So in primary healing, cartilage involvement is there. This is wrong. Woven bone is formed in primary fracture. Correct. Secondary healing, cartilage involvement is there. It common sense says if 2 is correct, 4 is not correct. Okay. So I told you second is wrong choice. So in that case, fourth becomes the right choice. In secondary cartilage, secondary healing, cartilage involvement is there. Immobilization, you know very well, is always a golden rule or is a must or a basic necessity for fracture healing. So what are the choices which are correct here? First, third, fourth and fifth. We'll go to the next question. Which of the following is not a marker of bone formation? You please understand, even in adult bone where there is constant bone formation and resorption. So that is a part of a calcium metabolism. That is a part of a calcium metabolism. Even though bone appears to be a static tissue, it is a dynamic tissue. Okay, so there is continuous bone resorption and continuous bone deposition. So you please remember this is very important for few things. One is it is necessary for a calcium metabolism or calcium homeostasis. Second is this becomes a basic understanding for osteoporosis, which I have explained you in the previous class. Okay, so let us come to, there are markers for bone formation. So whenever you are dealing with the diseases, there are certain markers which are picked up in the serum or urine. So if there is excessive resorption, which can happen in, just for an example, I will say in hyperparathyroidism or renal osteodystrophy. So in addition to other investigation, you will pick up certain markers in the serum which gives that there is resorption more than absorption. So what are the such markers? So which of the following is not a marker? Please read the question carefully. It is not a marker of bone formation. So you please understand, alkaline phosphatase is a marker of a bone formation. Okay. So again, alkaline phosphatase can originate from liver or bone. So to be specific, it is a bone specific alkaline phosphate is a definitely a marker for a bone formation. Now comes osteocalcin. Osteocalcin is definitely a bone formation marker. Pro-collagen peptide, which is a part of our organic matrix, is again a bone formation marker. So what is remaining? The answer is, which is not a bone forming marker, is serum cross-linked N-telopeptide. I will explain you in a minute. Okay, this is what I wanted to show you. Markers for bone resorption, markers for bone formation.
Excuse me,
So,
sir.
yeah.
Sir, we can't see your screen.
Oh my God. What happened? Only now you were able to see the other slides previously.
Hold on a second. Screen is missing. Sharing हो गया था नोड़ा.
Just a
Share.
minute.
Just share once more.
You can see now.
But I can't hear anything or see anything. It's just blank. ಅವ್ರು ಅದಕ್ಕೂ ಅದೇ ಹೇಳಿದ್ದಾರೆ ನನಗೆ.
ತಡಿ ನೋಡ್ತೇನೆ ತಡಿ ಏನಾಗಿದೆ ಬರ್ತದೆ. ಹಲೋ ಹೊಸಂಗಡಿ.
Yeah, I'm sharing, and once again, just check.
ಏನು ಕೇಳಿಸ್ತಿಲ್ಲ ಅಂತ ನಾನು ಕೇಳ್ತೀನಿ.
ಹಲೋ.
Hello. Can you see now?
ಹಲೋ. ಏನ್ ನಾಕಿಂಗ್ ಯಾರು ಹೊರಗೆ ಆಗತ್ತಾರ ಯಾರು? Somebody try to knock out.
Hello.
ಹಲೋ ಬಾಸ್ ಇದನ್ನ ಮಾಡು.
I have shared the screen once again. Has been allowed by Sakshi. Lobby.
Lobby ಬೇಡ. Don't activate lobby.
No, forget it. I got certain messages on the desktop. What I'm just reading. So, are you able to see the screen now?
No, not it.
See, lobby has been disabled by Sakshi. Students.
Don't activate the lobby, huh?
Students. Yeah. Students just unnecessarily don't click on any icons.
Just start that presentation once more.
Are you able to see now?
No, it's presentation start ಮಾಡು.
Okay, this is what is a presentation.
ಅವ್ರು ಯಾರು somebody clicks that presentation will disappear. ಮಾಡು.
You can see now?
No. Entire screen ತಗೋ. Hold on. Somebody has clicked it.
Should I do once again? Share your screen?
Yeah. Share once more.
Entire screen.
Yeah, entire screen you take. Pages. ಏನ್ ತಗೊಂಡಿ ಎಂಟೈರ್ ಸ್ಕ್ರೀನ್?
Entire screen.
ಕ್ಲಿಕ್ ಮಾಡಿದಿ?
ಹೌದು.
It is not coming yet.
So I'll only share application window, that is better. Just check if you can see me.
Hold on, I'll just. Can others see this one? Slides?
Shivani,
No, sir.
what are you seeing on your screen?
It's blank.
It's blank.
Yes, sir.
Can anybody see the slides?
No, sir.
Hello? Press the screen share ಮಾಡ್ಲಾ?
Sharing, man. See, Med PG is sharing a window. Stop screen sharing or hide.
ಬರ್ತಾ ಇಲ್ಲ screen share ಮಾಡಕ್ ನಿಂಗೆ?
My screen is already being shared.
Hello, ಸಂಗಡಿ.
Can you hear me?
ಸ್ವಲ್ಪ ಟೈಮ್ ತಗೊಂಡಿದ್ದ ಒಳಗಿನ. Hold on, ಹೊಸಂಗಡಿ.
Yeah. Can you hear me?
Hold on a second. The bandit. Hello?
Can you hear me?
Somebody,
Ah,
did you try to share the screen?
yes, I am sharing the screen. It is already appearing in my window that to hide the sharing or
Now
stop
it's coming,
sharing.
sir. Now it's coming.
Are you sure?
Yeah, sir.
Yes, sir.
All of you?
Yes, sir.
Shall I go ahead and continue?
Yes, sir.
That's great. That's great. Now can you see? Hello?
Yes, sir, we can see.
Okay, we'll not waste further any time. Okay? Okay, listen. So where I was okay. Marker, you please remember markers of resorption and markers of bone formation. We'll start with bone formation markers, which I think you very well will easily remember. Okay, so alkaline phosphatase. Many lab will have just checking serum alkaline phosphatase. Serum alkaline phosphatase. So if you check serum alkaline phosphatase and if it is raised, it is an indicator for as a bone excessive bone formation, especially in fracture healing. But please remember, it can be a marker of a liver disorder also. So total alkaline phosphatase is not a good marker. What is a good marker for bone formation is bone specific alkaline phosphatase. Please remember this. Fracture healing, if there is a fracture and it is healing, you do serum alkaline phosphatase, it is raised, provided the individual is healthy with not with any other comorbid condition. So, but you want to be specific with bone specific alkaline phosphatase, you can do that as well. But and osteocalcin, increased osteocalcin is also one of the bone formation markers. Pro-collagen type 1 propeptide is one of the bone markers. More importantly, I will come to this. Don't be confused with all of this. So there are certain clinically relevant bone markers for resorption, which indicate there is a excessive resorption happening. See, there is constant bone resorption and bone formation. But when there are markers in the bone for resorption, means there is rate of resorption is more than bone formation. That means there are certain underlying diseases which is causing excessive resorption. So bone formation is most oftenly in fracture healing. We'll come to clinically relevant where bone resorption markers in the serum or in the urine indicate certain bone resorptive disorder. Just for an example, it can be a malignancy or it can be a Paget's disease. Okay, so more important, you see this TRAP, they call it as TRAP, tartrate resistant acid phosphatase is one such. And one more important thing is urine hydroxyproline. Please don't get confused or don't really bother about this busy slide. Just focus on these important things. Excessive excessive hydroxyproline in urine is a marker for bone resorption. Okay, I'll go to the next slide. Yeah, this is what I want to reinforce once again. There is continuous bone resorption and bone formation. And what are the markers for bone formation? I told you, bone specific alkaline phosphatase, very important, and of course osteocalcin. In bone resorption, I was talking about urine hydroxyproline. To be more simplistic, you remember urine markers are picked up for bone resorption and serum markers for bone formation. But please remember trap. I mentioned trap, isn't it? Okay. Trap is a serum marker, tartrate resistant acid phosphatase, especially in metastasis, bone metastasis. Okay. Which of the following is indicative of bone resorption? We are here. I was talking of this. Can anybody, just to keep the class active and nobody dozes off, I expect somebody to answer this question.
Option 2.
Yes, urine hydroxyproline. Just it will be helpful for you to reinforce. Okay. Okay. Increase callus or cartilage formation is seen in. Please read this carefully. I'll come to relevant legend or the text or literature little later, but try attempting answering this question. Okay. Increase callus. So increase callus in a fracture. Increase callus, initially it can be cartilages, then it becomes bony. So increase callus in a cartilage or cartilage in a fracture is due to one of these. Just try ruling out one by one. You will arrive close to the correct answer. Yeah. Quick. Certainly, it cannot be necrosis of bone ends. Compression plating means the fractures are very closely reduced by open reduction and there is a plating applied with screws and compression plate. So there is now much of callus seen. So this is also wrong answer. Then comes your rigid immobilization or increased mobilization. Okay, rigid immobilization is nothing but plating once again. So that is also wrong. So what is remaining? Increased mobilization. See, if the fracture, you please remember, when a fracture is immobilized by a cast, plaster cast, especially in a forearm bones or in a child diaphyseal bones, they immobilize with a cast or spica. So you see so much of abundant callus because there is some amount of mobility remaining in the fracture site, and that is advantageous. Hence, it forms a excessive callus. This is an indicator for a secondary fracture healing. There is something called as primary fracture healing and secondary fracture healing, which I'll come to that later. So you understand what is the right answer in this? Excessive callus formation is because of increased mobility at the fracture site, to some extent. Okay, this is what I was mentioning. Fracture healing. So it can be direct healing or indirect healing. So direct healing means if the fracture is reduced hairline reduction and fixed by a plate, directly there is a bone formation. There is no what you call a cartilage formation and then endochondral calcification, ossification and healing. So direct healing is especially in a plating of a fracture. Okay, so direct healing can be contact healing, as I said, in a plating. Gap healing is in nailing. So what are the stages of healing is, initially as soon as there is a fracture, there is a hematoma formation. Then that hematoma is converted into cartilage. That is replaced by a bone. So this is a normal healing where there is a gap with the fracture, but it is fixed by a plaster or by a nailing. So what do you understand between direct and indirect healing? Once again, I will tell you. In present day, healing by callus formation is preferred. What I was telling you, I will show you some X-ray later on. If there is a gap, there is a excessive callus. This is a secondary healing because of excessive callus. Primary healing, however, is still desired. What is desired by orthopedic surgeon managing the fracture is is desired, primary healing is desired in articular fractures. Intra-articular means if there is a tibial condyle fracture like this, you want to reduce it very perfectly, because any step here causes the osteoarthritis. So here there is a primary healing, because the reduction is hairline and there is no gap. But in a diaphyseal fractures in a long bone tibia or femur, there is a secondary bone healing because of excessive callus formation. So, okay, this is quite a common law, of course not necessarily applying only to bones. Please read the question carefully. Wolff's law states that if a particular bone is continuously subjected to particular stress, it will adapt to become stronger and resist the loading. Diaphysis allows longitudinal growth in the childhood. Angular deformities progress till closure of the epiphysis, and any infection not showing periosteal reaction. Can anybody take this question? Apparently there are plenty of confusing choices, but the answer is straightforward. Yeah. Okay. Wolff's law states that particular bone is continuously subjected to a particular stress. It becomes stronger. So it is Wolff's law has to be applied even in your life also. If you find it hard, then you put a lot of effort, then it becomes easy. So more the stress, more the strong becomes the bone. Okay, that I will show you certain examples. See, Wolff's law, as I was mentioning, a tennis player, if he is a right-handed player, look at this. Look at the bone difference. That's why there are sometimes difference in the size of the bone. Very carefully. Strong athletes, right-handed athletes, badminton player, I mean whatever hand they are playing. So the bones are stronger, thicker, and wider. So that is because of the Wolff's law. Wolff's law. Wolff's law states what? So if they are subjected to stress continuously, stress is what? Any kind of loading, then that becomes strong. Similarly, some more examples of Wolff's law are bones are also less. So if there is excessive loading, they become strong, isn't it? So similarly, if there is no loading, where it can happen? If the patient is bedridden, or if there is no gravity in the astronauts, there is loss of bone tissue, they become weak. So no activity like in a diffuse osteoporosis or astronauts where there is no gravity or no loading of the bones become weak. So these are all some life examples of Wolff's law. Tensile strength of the bone is due to, okay, yeah, tensile strength of the bone is due to the what are the these are the components of the bone. Can anybody answer this? Tensile strength of the bone is due to. Okay, I will answer you for this. Tensile strength of the bone is because of the collagen. So you please remember, maybe I'm not sure if I have slide in subsequent presentation. See, bone is formed by a collagen, which is like a woven like this. It is like a rope. It is like a rope. So this is hardened by the crystals, hydroxyapatite crystals. So there are ropes here everywhere. There are ropes everywhere, and there is a deposition of the crystals. So imagine a rope in your day-to-day. pull it apart. So this is the tensile strength. You understand? A rope gives you tensile strength. The rope fails in a excessive tensile strength. But imagine a thick rope. Imagine a thick rope. It doesn't fail. If you compress it, it bends. It doesn't break because it is a flexible. Imagine collagen fibers are a rope. Okay. So collagen fibers are they are deposited with the hydroxyapatite crystals. So compressile strength. Imagine compressile strength means it is a brick. So if you stand on this brick, it doesn't fail. But if you keep the brick like this on two supportive structures, if somebody hits, you see in Jackie Chan movies or any martial arts, it fails. It fails here. This is a tensile force. Tensile force it causes a fracture. So what is responsible for a tensile strength? So bone has to tolerate tensile. You have anatomy bones. You try to pull the femur bone. Do you think it will fail? You hold the femur bone in both the hands and try to pull it. It doesn't fail. So it tensile. It is very, very strong. That strength is provided by collagen fibers. But if you put it on the knees and try to bend, it fails. Because on one side you are applying a compressile force. Okay, am I clear? Okay. This is some more diagrammatic representation I wanted to show you, where there's nothing much. Okay, this is long bone. There's a cortical bone. Cortical bones element, primary bone structure is osteon. That is formed by lamella. That further histologically, you see, this is what I was talking. These are collagen fibers, where imagine the bone like a column structure of a building. If you see a building, there are first lot of iron rods are put, then cement is applied. So the columns are considered as collagen fibers. What you put cement is a hydroxyapatite. Okay, this is same continuation. Oh my God. Sorry. Okay. Yeah. How the fractures happen is basically you should understand. See, I was telling you, you stand on this femur, it doesn't fail so easily. But if you put excessive load, it fails because of the compression. But if you take this bone, imagine you take a small stick or pen and try to bend it, it fails here. So here you are applying a fulcrum. Here it is a compressive force. Here it becomes a stretching. Stretching is tensile, to make it simple for you to understand. Tensile is stretching. Compressile means they come close to each other. Bone resorption is inhibited. Bone resorption is inhibited by. You should tell me this. You should tell me this answer. If you attended my previous classes, of course, there is a repetition from some other class as well, but you can easily answer this. Bone resorption is inhibited by. Anyone, right or wrong? Take a chance. So answer is easily estrogen. So women bone are protected in prior to menopause is because of estrogen. Estrogen reduces or prevents bone resorption. Once the women attain menopause, bone resorption is increased. Hence, estrogen is bone protecting, or it reduces the bone resorption. Hence, it protects the bone, women's bone, from osteoporosis. Okay, this will not go here. Diagnostic sign of a fracture. This is very simple. If you are alert now in the class, I expect you to answer this. Diagnostic sign of a fracture. Very simple. Very, very simple question. Quick.
Swelling.
Swelling. Diagnostic. There can be all the features, but I want something which clinches. Swelling can be there even without a fracture.
Option
No.
4.
Yeah. There can be pain with or without fracture. There can be swelling without fracture. There can be wound without a fracture. But abnormal mobility is the sign for a fracture. Okay. Direct impact. I was telling you, suppose you are walking on a road, you are a pedestrian, a motor vehicle hits you. So that is a direct. The fractures can happen because of direct injury, direct impact. The force directly acts on the part of the body, or it acts indirectly. I will give you some examples little later, but let us focus on this question right now. Direct impact on the bone will produce what kind of the fracture? Can anybody answer this?
So
Oblique.
Yes. Good. Who was that? See, so for this you should understand. Imagine you are holding a chalk piece. You try this literally at your room or home, wherever you are staying. You try to bend it, it causes a transverse fracture. If you try to twist it, it causes a spiral fracture. Okay? So spiral fracture means if the fracture goes like this. Transverse fracture is like this. So one thing you please remember, this can be a question sometime later. Transverse fracture is this, and oblique fracture. You have to understand the difference between transverse fracture and oblique fracture. Transverse is perpendicular to the long bone, but in real life situation, it cannot be always 90 degree. So one thing you understand, transverse fracture means if the angle formed by a fracture to the long axis of the bone is less than 30 degrees. Please remember this. So a fracture can be exactly 90 degrees, or it becomes like this. Only if it is more than 30 degree, you call it as oblique fracture. You please remember this. I'm sure will be in some appearing in one or other examination. So difference between oblique and transverse fracture is the angle formed by a fracture should be less than 30 transverse, more than 30 it is oblique. Okay. Comminuted fracture. So if you suppose you are lying down on the road, run over by a vehicle, or somebody in a violent mob crushes on the heavy boulder on your leg. So these are a direct fractures that can really cause a comminuted fracture. Causes of fracture, okay, some just to break the monotony. Direct force also, bones break at the fracture site of the impact. So one more thing is, you should remember, how will I know whether the fracture is because of the direct or indirect impact? So there can be telltale signs on the skin. There can be ecchymosis, or there can be abrasion, there can be CLW. So directly on the fracture site. Understand? So before the fracture or the bone fails, a skin and a connective tissue fail. So direct force, you see there is a bones break at the site of the impact. Okay. Indirect force, you apply force elsewhere, the fracture is somewhere else. Suppose you are playing a football, you are twisting the ankle, you fall or somebody twists your ankle in kabaddi or whatever. The fracture need not happen at the ankle only, it can happen anywhere. Or similarly, you fall on an outstretched hand, there can be distal and radius fracture, elbow dislocation, there can be up to clavicle fracture, it can happen anywhere. So even though the wrist touches the ground, if the wrist touches the ground and fracture happens there, it is a direct fracture. But the force transmitted anywhere along the axis of the upper limb, the fracture is indirect fracture. The force is applied elsewhere and fracture is similarly elsewhere. Similarly, if a person falls either suicidal or accidental from a height, he lands on the heel. If there is a heel fracture, it is a direct fracture. But if there is a vertebral fracture also, look at this, the weight is transferred like this, isn't it? There can be vertebral compression fracture. It is again because of the indirect force. Heel fracture is because of the direct force. Am I clear in this? Okay. One more important thing before I finish this part of discussion, please understand. So there can be fracture because of the direct or indirect force. There can be fracture because of excessive or violent muscular contraction. Example for this is fracture patella. Severe contraction of the quadriceps, there can be avulsion of a patella. Similarly, tendoachilles avulsion can happen. Strong bones, if they contract excessively in sports or otherwise, you will have a fracture. These are avulsion fracture. Understand? Twisting pathological fracture. Fatigue fracture is bone is normal. Bone is normal, but subjected to excessive repeated stress. Excessive repeated stress. I told you stress fracture. I have discussed about the March fracture. Suppose there is a new army recruit who has joined the army recently. He is asked for a everyday running in the morning, in the night. He will develop some stress fracture because he is not used to that kind of activity. So stress fracture can happen from foot to the neck of the femur. I will not explain, I have done that already. But most common stress fracture or fatigue fracture is March or a second metatarsal bone fracture in the foot. But what is the difference, as I was telling? Pathological fracture here is normal force fractures the bone because the bone is abnormal or it is a diseased bone. Understand? Even if there is already a malignancy, patient just falls, just like in osteoporosis also. He just trips and falls. That just simple fall in young patient will not cause a fracture, but in old it causes a fracture. That is a pathological fracture. Am I clear? Okay, this is one more such diagram. So only indirect and direct fractures. I'm not going to that. One more repetition. Okay. Most common sign of fresh fracture. Yeah, I want somebody to answer this. Most common sign of fresh fracture. Quick, very interesting question it is. Come on, quick. Hello? Okay. So, if nobody is willing, then I will continue. Crepitus. Is it right? No, because crepitus can happen even in bursa. So that is wrong. Bony tenderness. Yes. Deformity even in old fracture. Abnormal mobility even in old fracture. So what is remaining most common sign for a fresh fracture is tenderness. Initially the fracture is painful. If you leave alone, whether the fracture unites or doesn't unite or goes for a non-union, it becomes painless. Remember. So acute or fresh fracture is painful. Pain, bony tenderness is a most common sign for a fresh fracture. Okay, this is one more important thing you should understand in a fractures. In compound fractures are classified based on Gustello-Anderson classification. I have few slides which will make you remember thoroughly, that you will not be confusing at all. Okay, Gustello-Anderson is a classification for open fractures or compound fractures. So what is open or compound fracture is? Open means the fracture is open to the environment. Closed fracture or a simple fracture means skin is not broken. Okay, Gustello-Anderson classifications are classified into 3 types. 1, 2 and 3. 3 is further A, B, C. Even though this slide appears very busy, please don't be disheartened or disappointed. Grade 3. Okay. Again, okay, I will come there. But please remember, Gustello-Anderson is a classification for open fractures. It is classified in 2 types, 3 types. So third is A, B, C. I will simplify that further in my next slide. Okay. See, here I am. So when do you call type 1, type 2, type 3? See, when the wound is less than 1 centimeter, it is type 1. Type 2 is more than 1 centimeter. Just remember the size of the wound. Type 1 less than 1, type 2 more than 1. Simple. Okay, don't bother about the other things. Type 3 is don't go on the size of the wound, extensive soft tissue damage, severe crushing, type 1 less than 1 centimeter, type 2 is more than 1 centimeter, but no extensive soft tissue damage. ABC, there's an interesting slide where I have found here. Okay, I will come to that. So ABC, 3 ABC. So make it very simple. Less than 1, type 1, more than 1, type 2. Type 3, don't go on the size of the wound. Type 3, you will remember easily. It is associated with the vascular injury. Now you have to differentiate between A and B. I will come to that in the next slide. See, here again you see I am only focusing on third ABC. So this is very interesting slide. 3 ABC means A is adequate soft tissue coverage is there available. B, soft tissue is very bad. You need additional coverage in the form of flap, skin grafting or other things. C means circulation is impaired. Very, very interesting slide I could find. So third ABC, how do you identify is don't go on the size of the wound. Soft tissue, adequate soft tissue coverage is there for the fracture. B is you have to do a surgical coverage. Means bad. B, A, B, C. A is adequate, B is bad, C is circulation or arterial injury. Okay, right. So with that, we'll come to this question now. A patient with an open wound. See, read this carefully. A patient with an open wound, fracture of both bones, that is tibia and fibula of the right leg. Casualty duty doctor labels that as a 3B. 3B is Gustula Anderson 3B. What does he mean by that? See, he calls an orthopedic surgeon on call. Duty. Imagine yourself being on duty. He, as a postgraduate, wishfully of orthopedic postgraduate, he will call your consultant saying that there is a fracture 3B of right leg. What does that mean? Hello? Okay. Open fracture less than 1 centimeter. Definitely no. I told you this is a Gustula Anderson 1. Open fracture 1 to 10 centimeter. Mild soft tissue injury. Definitely no. It more than choices. More than 10 centimeter. Okay. Both are same. You focus on soft tissue injury not requiring coverage. Soft tissue injury requiring coverage. So not requiring coverage is 3A, requiring coverage is 3B. Vascular repair is needed in which type of Gustula Anderson? Quick.
3C, sir.
Excellent, excellent. I want somebody to keep talking, otherwise I see only my PowerPoint presentation. I don't know who all are still there in the class. 3C, excellent. Internal fixation is primarily used in all except, okay, internal fixation is primarily used in all, remember, except, okay. Come on, let's see, even though you have never heard or answered or read before, try attempting the question very logically. Most of the time the choices are so illogical, you can easily arrive at the right answer. Okay, see, internal fixation is very essential for multiple fracture because you can't put plaster everywhere. So that is correct. Fracture in elderly, you have to do internal fixation so that they will be up and above. Any fracture we do fixation because we have to make them ambulant, make them take care of their hygiene needs or daily needs. So fracture in elderly, if you make them bedridden, then open fracture you have to treat by external fixation. So a foreign body you cannot put inside the bone if there is a wound because there is a chance of, very high chance of infection. Am I clear, students? Okay. Crush syndrome. One or two more topics. I'll quickly wind up. Okay. Crush syndrome. I'm sure you have heard of this. What is right here? Quick. Come on. Most common in earthquakes. Yes. Causes acute glomerulonephritis. Wait, don't know. Increased myoglobin, yes. Because of crushed muscles, there is release of myoglobin into the blood. Correct. Due to, of course, massive crushing of the muscles, no doubt. So whether it causes ATN, this acute tubular necrosis. crush syndrome is managed by? Always you remember, the excessive myohemoglobin or myoglobin gets into the circulation where the molecules are very high. It clogs our renal tubules. It causes acute tubular necrosis or acute renal failure. Acute renal failure. So what is important is you have to maintain high urine output by giving excessive colloids. Okay, yeah, here you are. Crush syndrome is a manifestation of muscular injury. Prolonged muscular injury. People have had crush injury if they have dosed off with heavy drugs or alcohol and lying on one limb for more than 24 hours. They also have had a history of crush injury. Commonly found, of course, in earthquakes or when they are buried alive under the rubble of the earthquake buildings. So what are the signs? That part which is compressed or gets stuck or sandwiched become tense and edematous. The patient's urine, when moved out to the casualty, you see there is a dark colored urine. Of course, he goes for a shock. There is metabolic acidosis and acute renal failure. There is one slide, interesting slide. You please see this. See, if there is a crushing of the leg, what happens? The muscle goes necrosis, myoglobin is released into the blood vessels. It gets clogged into the, it gets excreted in the urine. So hence the dark colored urine. But excessive or there is no perfusion or volume loss is there, it can cause acute renal failure. Of course, there is a metabolic acidosis because there is no blood supply here. Anaerobic metabolism happens and it causes release of lactic acid. Potassium from the crushed muscles. Creatine kinase again is all the origin from the muscles. So quickly I will tell you about the treatment, medical management and surgical management. So medical management is the whole crux of crush syndrome. Medical management is fluid replacement. If there is excessive metabolic acidosis, patient is going for a respiratory failure, he will require a ventilatory support. Of course, you have to do correction of metabolic acidosis. If the patient goes for a renal failure, he will require a dialysis. So what you do to the part? What you do to the part which has been crushed? You have to do fasciotomy because crushing can, once you remove this, the thing which is compressing, there is the blood circulation restored and it causes reperfusion injury. Remember this. Reperfusion, excessive perfusion of the part causes swelling and hence it causes compartment syndrome. And this leg becomes unviable. So what you have to do is, you have to do fasciotomy to release the compartment pressure. Debridement, necrotic tissue you have to debride to prevent infection. And of course, the wound management by skin grafting and other things. So pathological fracture, yeah, I was talking of pathological fracture. I think any one of you quickly can answer this. I have left with only 4 or 5 more questions. Not found in, quick. See, bone cyst means it has, bone is weak, there will be a pathological fracture. Osteoporosis, you know, it is most common cause for a fracture, pathological fracture. Chronic osteomyelitis is also cause for a pathological fracture. Osteogenesis imperfecta, the bones are fragile, very fragile bones are there. So it is osteochondroma is not a cause for a pathological fracture. You please remember, don't misunderstand this question. I will draw a diagram of a femur. You will see there is a osteochondroma. Please remember, osteochondroma grows away from the growing end. There is a possibility of this fracture. The osteochondroma, there can be a fracture, but this doesn't cause a pathological fracture of a bone. Please remember this. Osteochondroma complication is malignancy, malignant degeneration, or there can be a fracture of the stalk of the osteochondroma, not the bone per se. So this will be the appropriate answer in this question. Treatment of choice in pathological fracture. Yeah. See, any fracture for that matter can be treated with the plaster, that is POP, or surgery by putting rods, internal fixation or external fixation. So all this could appear right, isn't it? So please remember, pathological fracture, the pain is not only due to fracture here, the pain is also because of the metastasis. Metastasis also causes a severe pain. So internal fixation is the right answer. POP doesn't heal because there is a loss in the bone. Skin traction is no use. External fixation is again no use. Okay, Merrill's criteria. This, of course, no exaggeration. I have picked up from a previous exam only. You might feel it is a difficult question, but you please remember, don't try to be disappointed by the name. Merrill's criteria is for pathological fracture. Please remember this much. If you remember, you can answer 1 or 2 questions based on this. So Merrill's criteria is for risk of pathological fracture in metastasis. You can predict. Yeah. Again, please understand, there is nothing much. Very easy. Don't try to remember anything. Merrill's scoring is depending upon whether upper limb, lower limb, or trochanteric. Don't try to remember the scoring at all. So, if there is a metastasis here, upper limb chance of fracture is less. Around trochanter, chance of pathological fracture is high. You remember. Disappointed that you will not be able to remember. Again, if there is a metastasis, there is a severe pain or a functional pain, there can be a high chance of pathological fracture. You look at the X-ray. If there is a blast lesion in a CA prostate, lytic lesion in a CA bronchus, or CA renal cell carcinoma, lytic means it is already weak, chances are very high. If the size of the involvement of the cortex, if it is only 1/3 involved, the chance of fracture is less. So the take-home message is, please remember, Merrill's criteria is for predicting the pathological fracture in metastasis. If you just remember this one sentence, my day is done. So Merrill's criteria for predicting pathological. You see a CA lung, CA prostate with multiple metastases all over the bone. You look at the X-ray, you will know whether there is a high chance of fracture or low chance of fracture based on Merrill's criteria. Very simple. So now 1 or 2 questions about the non-union. Hypertrophic non-union following a fracture, most appropriate treatment. Most appropriate treatment is internal stabilization. You see patients coming with patients nowadays, even in village side, they go to quacks or osteopaths. So what they do, they'll just apply some bamboo stick and you see non-union. So at that stage, if you see what you have to do, whether you want to do internal plate and screw fixation or nailing, bone grafting, stabilization and bone grafting, or POP cast. See, the choices are very interesting. POP cast definitely no, because he has already exhausted the immobilization, way of immobilization. So this is not a choice. What is this? Is not a choice. So what he has given here, hypertrophic non-union. Hypertrophic non-union. So the choice is only 3 now. Bone grafting, stabilization and bone grafting, or internal stabilization alone. The answer is internal stabilization. I will explain you in a minute. Okay, so for that you should know what are the different types of non-union. See, non-unions are classified as vascular and avascular. Please remember this. The ends of the bones are vascular. If they are vascular, means biology is still not dead. The power of healing understand. So how will you know? On X-ray you can easily make out whether the vascularity of the ends are remaining or completely disappointed. So based on the appearance of X-ray, they have been classified as hypertrophic or atrophic. Hypertrophy when it happens is when there is a vascularity, isn't it? I'll come to something. Look at this. Look at this fracture. Even though this is a old fracture, because the edges are ragged and rounded, you see so much of abundant callus you've seen. See here, there is still callus but no fracture union. Look at this, there is less fracture. So based on the amount of callus they throw, they are classed as elephant foot. Look at this. It looks like an elephant foot, isn't it? Look at this. This is a horse hoof, less than elephant foot. Okay, and oligotrophic. So based on the amount of callus what you see on the X-ray, they are classified as this is a vascular non-union. Vascular non-union. This is a avascular or hypertrophic or atrophic. Okay. So hypertrophy can be elephant foot, horse foot, oligotrophy. Look at the pictures below. Don't go into these words. Please don't be really confused. Don't try to remember all this, but just remember atrophic. There's no callus whatsoever here. There's no much callus. These are all bone fragments. There's no callus seen. This is very, very less. They have become like a pencil tip. So this will indicate us what we have to do. So here the biology, the nature has attempted to heal. Here nature or biology has failed for the fracture healing. So in hypertrophic, or if there is any callus formation, what is required is immobilization. Immobilization. So if they put cast and they have thrown callus, means you have to do internal fixation. Means there is life in the fracture which is trying to heal, but because of repeated mobility, it is not immobilized properly, either internal or external, it has not healed. So biology is intact, you have to immobilize or internally stabilize. But look at these fractures where there is no life at the fracture. So what you have to do? Definitely you have to fix and you have to do bone grafting, because you have to supplement or support the biology. Here you have to do only fixation. Bone grafting is in atrophic or avascular non-unions. Am I clear, friends? Okay, this is one slide just to show the stages of healing. Hematoma formation, cartilage, bony callus, and bone modeling. So please remember one more thing, an important thing about this slide is hematoma formation at fracture site is very important precursor. Very important precursor for fracture healing. That's why in open fracture, the hematoma gets drained out completely. That's why open fractures, there is a delayed healing. Closed fracture heal quickly. Open fracture heal slowly, or chance of non-union because there is hematoma which is lost. Fracture healing is affected. This is again one more interesting question what I picked up. Fracture healing is affected by all except, yeah, anybody? Quick. See, poor blood supply, yes, lower end of tibia, there's poor blood supply because not covered by the muscle, fracture delayed union. There's a soft tissue interposition. Now comes between infection and osteoporosis. Infection definitely delays the or effect on the healing. Osteoporosis causes pathological fracture, but the healing is not abnormal. Please remember that. Okay, time necessary for this is again one more interesting question. Time necessary for fracture healing depends on all the following factors. Except, can anybody answer this? Age of the patient, yes. Younger the patient, the fracture heals quickly. Gender, before that we'll go to type of fracture. I told you open fracture delayed healing, late healing, and closed fracture quick healing. Location of the fracture, again metaphyseal bone heal very quickly than diaphyseal bones. Damage to soft tissue. See, bone draws blood supply from a endosteal circulation and from a surrounding muscles by a periosteum. So damage to soft tissue means, or open fracture, again there is a delayed healing. So you have never heard that there is difference in fracture healing depending upon the gender of the patient. Fracture healing duration is same whether for males or females. Such a wonderful question, this one. Okay. Thank you. Shivani is still there?